Good afternoon, ladies and gentlemen. Today I'm going to talk about the importance of physical therapy in the ICU world. I have no disclosure to talk about. The main points I'm going to talk about today is going to be the problems with bed rest and immobility in the beginning and the complications of immobility, physical therapy interventions in the intensive care unit, outcomes of early mobilization and physical therapy involvement, physical therapy for the management of airway secretions as well, safety of physical therapy in the ICU, and where we are at Henry Ford. In the beginning with talking about the bed rest and complications and the growing need for physical therapy in the ICU, our population, patient population that we see every day in the intensive care unit, they are frequently exposed to prolonged immobilization. And accordingly, the ICU acquired neuromuscular complications are common to see, which debilitates the patient and cause more long-lasting outcomes and side effects. We don't usually. What is it? Just close?
Yeah.
We don't usually feel these outcomes because the patients experience this after going out from the ICU and even going out from the hospital. They have effects on their quality of life and many other issues we need to talk about. And also the ICU acquired weakness is associated with the prolonged mechanical ventilation, the longer ICU stay, the longer recovery time, and the marked decline in their function status in the ICU. In the United States, there are more than 4 million ICU admissions per year, and with the progressively aging population, the advancement of medicine, the extension of the ICU care, there is a higher number of ICU survivors every year. Those survivors, they suffer from late morbidity, neurocognitive defects, mental and functional problems, which in turn cause more impairment on their quality of life in the future and difficulty returning back to their usual activities and going back to work, causing more and more major burden on the patients, their families, and the healthcare system, which cause higher rates of institutionalization and recurrent admission and higher cost of care. When I mention immobility and bed rest, I have to start first talking about the complications that happen and that we have to be aware of to go further with the physical therapy and minimize these complications. First, talking about the respiratory. With the bed rest, compression of the abdominal contents on the chest, the diaphragm, and affection on the respiratory movements, that's going to cause higher risk of atelectasis, decrease the clearance of the tracheobronchial secretions, the mechanical ventilation as well, the prolonged mechanical ventilation would put the patient at the risk of ventilator-associated pneumonia, higher risk of DVTs and pulmonary embolism. Man, there's something there. Should we keep the current colors? Yeah. Okay. And also, the mechanical ventilation and the bed rest can cause weaker respiratory muscles. Talking about the diaphragm and the weakness that happens with the mechanical ventilation, there are main three mechanisms happen. Basically, the change in protein turnover promotes promotion of oxidative stress injury with the mechanical ventilation, with its effects on the diaphragm, and changes in the gene expression and cell signaling. About the protein turnover, there were two main studies done. There was an animal study done on rats. They brought 42 rats. The main goal of the study was basically to compare the mode of the CMV, the control mechanical ventilation, versus the pressure controlled ventilation to see the usefulness, if there is any difference. But this is not our main goal of our talk today. But on the rats, the CMV mode, it decreased the protein sensitive by 50% after 6 hours and by 65% after 18 hours. On another study done on the human, basically brain dead organ donors, after 18 to 69 hours of CMV mechanical ventilation, it led to increase in protein degradation too. The second mechanism is the oxidative stress injury, which basically promotes the diaphragmatic atrophy and the contractile dysfunction. In patients who are on the same study, if we put the patients controlled mechanical ventilation for more than 6 hours, there is increase in protein oxidation, lipid peroxidation, and diminishing in antioxidant capacity and other enzymatic changes to promote the same mechanism. Effects go and extends more, reach the cell level and the gene expression. More than 350 changes in the gene products after 6 to 18 hours of the mechanical ventilation. And these genes linked with the stress response, the protein metabolism, and calcium regulation. All of these changes can gonna affect the diaphragmatic muscle and cause more weakness. About the complications of immobility too, the skeletal muscles gets weaker. The strength decreases by 20% every week with bed rest. And the healthy individuals, after 5 days of bed rest, they were found to develop insulin resistance and microvascular dysfunction in one of the studies. Rapid muscle atrophy comes primarily because of the bed rest, and if there is a casting of one of the limbs after polytrauma in the surgical patients, or can happen secondary to the critical illness, polyneuropathy and myopathy too. The first muscle groups that start to lose its function are the muscles maintaining the posture and ambulation, which is basically going to affect the patient's quality of life and function when the patient gets out of the unit and the hospital. A study was done on healthy young volunteers. 28 days of bed rest caused 0.4 kilogram loss of the lean leg mass with 23% reduction in the leg extension strength. On the healthy older adults, 10 days of bed rest caused loss of 1.5 kilogram of the whole body lean mass and 15% reduction in muscle strength. A lot of numbers, but that explains how much difference and effects on the patients when they lay in the unit and with the bed rest and immobility. The rate of muscle centers decline quicker after the onset of muscle inactivity within 6 hours. And the skeletal muscles start to reach a new lower steady state of protein synthesis within 18 to 48 hours. And this protein synthesis, when it goes down, it's basically the primary factor causing the disused muscle atrophy. These effects gets more amplified with the changes that what I talked about before on the healthy persons. But now these changes get more intensified if the patient has severe sepsis or in severe trauma. In 21 days, the patient lose total body protein, about 16% in the injury, critical injury, and 13% in the sepsis, and most of the protein losses from the skeletal muscles, which cause more weakness too. What happens in the ICU with the immobility? Also the neuropathy and myopathy. That happens basically because of the hypotension, development of microthrombi, and the neural edema, myocardial dysfunction, with our use of corticosteroids for different problems that has a metabolic and a catabolic effect on the muscles and also affect the nerves, an increase in the protein degradation with the mechanisms I talked about earlier. More and more complications affect the cardiovascular system, the musculoskeletal system. The patients we see the DVTs with the immobility, with the complications, and PE, the diffuse ulcers. A lot of these complications we usually see. And overall, the elderly are more vulnerable to these complications. And as you know, our patient population are more from this age group. Prolonged mechanical ventilation, in turn, cause increase in morbidity and mortality, increase the respiratory muscle weakness, and increased duration of mechanical ventilation. Accordingly, higher cost of care, increase the length of stay, the sleep deprivation, the lack of social interaction with the longer ICU stays, the prolonged sedation and delirium. Now we're going to talk about the physiotherapy and interventions in the ICU. First, the usual care. That's basically provided by the nurses in the ICU. That's when the patient start to, when the patient is unconscious, they start to do some passive range of motion, turning in the bed every 2 hours. And when the patients start to regain consciousness, they help the patients to do some exercises in the bed, helping them to sit up in the bed, sometimes sitting at the edge of the bed. And when more awake and interactive, they set the patient up, try to ambulate, sit to the chair next to the bed. The physiotherapist and occupational therapist starts to intervene as well with mobilizing the patients, and their interventions are more intense than the usual care provided by the nurses. They do the same interventions the nurse does, but also they do more extra. They do more frequent during the day and on a longer courses. They do the same passive and active range of motion, active side-to-side turning, cycling in bed either with upper or lower extremities, exercising in bed, transferring from the bed to chair when the patient is able to ambulate and get up, march on the spot, the tilt table sometimes, but we don't see it that often, and active resistant exercises too. Here you can see the physiotherapist, and also that can be provided by the nurse, doing some passive range of motion. The patient in the intensive care, a trach patient, and you don't keep the patient just immobile and sitting in the bed having all the complications. Another one connected to the CRRT machine, and you can see here even the patient has a femoral dialysis line, and that's not preventing him from having physical therapy. The patient is doing cycling in the bed. This is not a contraindication, being the patient in the unit or having dialysis catheter, femoral line sometimes, or being on the CRRT. We have to be more proactive in teaching the team and the staff and about the importance of physical therapy. When the patient get up from the chair, they can do still some cycling by the upper extremities, which improves the upper body muscle mass and strength, and according to the respiratory function, and prevents the complications that we see later. Intubation is not a problem. Intubation is not a limit for the patients to get up and walk. You can see here, like the patients are intubated on the mechanical ventilation, and they walk with the assistance of the team. And it has. I will talk about it later. There's no safety concerns about it, but we have to be more proactive and educate our nurses and staff about it. There were many publications talked about physical therapy and the interventions in the ICU and the positive outcome. This is one of the meta-analyses that was published in 2013. They included 10 randomized controlled trials talking about the physical therapy. They compared it between compared it with the usual care provided by the nurses. The interventions were different from study to study. Also, the timing of initiation of physical therapy was different between the studies, but which you can see here, like they started at different periods and their inclusion criteria were different. But regarding the points, the major outcomes that they studied, so the studies talked about the physical function favored the physical therapy. The patient had better physical function after ICU discharge. About the quality of life, the studies studied that about, and they have their specific scores and indices to measure these outcomes, favored physical therapy. The peripheral muscle strength was also favored in the physical therapy group. The respiratory muscle strength favored in the same group. Ventilator-free days, some of the studies showed that patients get extubated even earlier with better strength and better respiratory muscle function. The length of hospital stay was less in some of the physical therapy group. Length of ICU stay, there was no difference, much difference in mortality between the two groups. The physical therapy and interventions can be used also to help to manage the airway secretions. Four main mechanisms we do, like or techniques we do to help with the airway secretion, the postural drainage, the manual hyperinflation, the in and exsufflation, and the intrapulmonary percussive ventilation. So the postural drainage, many techniques can be done for that, which we usually do in our units, like gravity-assisted position, deep breathing exercises, chest clapping, shaking, vibration, that's provided by the sports bed and the other tools that we have, the incentivizing the cough and clearing the secretions. Many studies try to talk about this and measure the outcome of using these interventions. So a randomized control trial was done on mechanically ventilated patients in the ICU and suggests that percussion and postural drainage might prevent the occurrence of lung collapse, not only for the treatment of it. Another study showed that chest physiotherapy was useful in prevention of ventilator-associated pneumonia. The intervention group, the control group had 39% ventilator-associated pneumonia, compared to 8% in the intervention group, which was statistically significant in this study. Another study showed that the critically ill obese patients under the mechanical ventilation, when you set them up, there is improvement in the expiratory flow limitations, the intrinsic PEEP, which are the interventions that we have to think about in patients on mechanical ventilation when we have problems with the pressures, to like some of the techniques and tools that we can do to help with their mechanics. Manual hyperinflation is, this is a bit controversial about the safety of it. It's provided by the respiratory therapist. They do it manually. They do like deep inspiration, slow, then they hold, then fast unobstructed expiration. The main goal of this technique is basically to try to move the secretions to the main large bronchi that can be suctioned after, in order to help and prevent the occurrence of lung collapse and infections and pneumonia. But this is not very common in our institution, but it's done in some other areas, and it's still controversial. The intrapulmonary percussive ventilation can be done on the ventilated or non-ventilated patients. It's basically the high-frequency ventilation. It helps also to clear up the secretion, causing like some cough-like movements, and help to prevent the same occurrence of lung collapse and the pneumonia, and helps also for alveolar recruitment. It was some of the people in the past was studied and was administered to the patients with ARDS as one of the protocols to recruit for recruitment criteria. A study was done on the intubated COPD patients and showed that this intervention reduces the expiratory flow limitations and gas exchange. Another randomized controlled trial showed that there is an improvement of gas exchange and the expiratory muscle performance, and reduced the incidence of pneumonia. The in and exsufflation, it's the cough assist device. It's basically applying a positive pressure, then and rapidly shift to negative pressure. So produce a high expiratory flow and help to get rid of the secretions too. This study by Chatwin and his colleagues showed that they compared the conventional physical therapy with the physical therapy plus the in and exsufflation in non-invasively ventilated patients, and showed there was a shortening of the ICU stay, but they didn't see much of a change in the airways, in getting rid of the airway secretions. So what are the other interventions the physiotherapy people can do for the critically ill patients? The neuromuscular electrical stimulation in mechanically vented patients. So at Johns Hopkins, they applied these techniques to help to improve the muscle power and strength. They had a randomized pilot study. They controlled this intervention with the sham, which is a kind of like placebo interventions, and on the 3 bilateral lower extremity muscle groups for 60 minutes daily in the ICU, and they included all the patients from the medical and surgical ICU. And the primary outcome was the lower extremity weakness, lower extremity muscle strength at the hospital discharge, using the MRC score. And the secondary outcome at hospital discharge, including the walking distance and change in lower extremity strength. And this actually stopped the enrollment after enrolling 36 patients because of funding issues. But the studies showed that there was a main increase in the primary lower extremity MRC strength from the time of awakening to the ICU discharge and to the hospital. There was significant difference here, quite a difference between the two interventions favoring the neuromuscular electrical stimulation. Another study was done on the traumatized patients, polytrauma patients within the first 24 hours, and showed reduction in the quadricep. There were reduction in both groups, but there was much less in the intervention group. Here, the way they do it, they apply the pad here connected to the device, and they start to adjust the frequency and amplitude of the stimulation according to the patient, and they have their own criteria. This is kind of similar to the tools and devices that we have, the train of 4 that we use in the paralyzed patients. Also,
primary motor. So so the only thing that is increased in the lower extremity strength, right?
yeah, just the strength. So it didn't affect the.
It didn't affect anything
No,
else.
yeah, just the strength. And as I mentioned, this study was they stopped enrollment of patients early. Also, like they didn't complete it as complete the power as per protocol because like there was lack of funding at that time. Also, use of video games and physical therapy, basically using the Wii, the Wii hat. So at Johns Hopkins, they started to use actually the Wii is kind of one of the tools that they use at the outpatient physical rehab and physical therapy. But they wanted to assess the usefulness and the safety of these interventions in the ICU. And you see here, like the patient is intubated, like ventilated, standing here and playing like boxing with the Wii. They applied the boxing, the bowling, and the balance boards. The main goal of the study was not to assess the usefulness or the outcome of using the Wii compared to the other interventions. It was basically to assess the safety. And it was so safe for them, and they didn't have any adverse events. They didn't have any extubations or something. Patients felt it was fun. I'll show you a lab. So here's the question. Is it safe to mobilize and ambulate the mechanically ventilated patients? That's always the concern. Like we have the patients intubated and we think, no, they cannot participate and get up. A study was done and published in 2007, a prospective study done on mechanically ventilated patients for more than 4 days. All of them were either trached or intubated. And they measured the outcomes. The interventions they did was sitting in the bed, sitting in the chair, or ambulation. And the adverse events they were monitoring fall to the knees, any tube removal, like any of the feeding tubes, having blood pressure systolic more than 200 or systolic less than 90, desaturation less than 88% or extubation. And the results were good. Like the patient did not have, there were less than 1% activity-related adverse events, and no single extubation happened. And 69% of the patients were able to ambulate more than 100 feet at the time of ICU discharge. So basically, it's early activity is safe and feasible in the mechanically intubated patients. Shouldn't be an obstacle for our interventions. The main criteria to consider early activity initiation and involvement of the physical therapy. First, the patient is responding to verbal stimuli and interactive. The patient is on not high settings on the ventilator, less than 60% FiO2, less than 10 of PEEP, and absence of orthostatic hypotensions and inotropic drip. It's not a contraindication having an inotropic drip if the patient is on one drip and not on a high rate, and that can be considered and assessed by the clinician following the patient and collaborated with the physical therapy team. But if there is a high need, if the patient is requiring higher rates of and increasing the rate of the pressure, that's a different issue. The mobility and the assessment and step-by-step mobility process should be assessed every day, and that's what we do daily in our ICU rounds and in multidisciplinary rounds. We assess the patient level of mobility and the goals for today, which should be an important point to talk about every day. The first is the level 1, when the patient is unconscious. So the mobility team start to do the passive range of motions at least 3 times per day, and few 2 hours turning in the bed. Then when the patient start to get conscious and more awake, the same interventions, adding to that active resistance by the physical therapy when they start to get involved, and sitting position, sit the patient in the bed at least for 20 minutes, 3 times per day. When the patient starts to move the arm against gravity, you move to the next level. Adding to all of the previous intervention, you try to sit the patient at the edge of the bed with the help of the mobility team and the physical therapy. And when the patient is able to raise the leg against gravity, you go to level 4. The patient, the physical therapy team encourage the patient to move and go to the chair, ambulate, and be more independent at least 20 minutes per day. The ultimate goal for these steps and intervention is to promote the maximum level of independence before the hospital discharge. It's our goal every day to progressively move the patients and go ahead with the upright mobility process. When the patient is unconscious, we start with raising the head of the bed 45 degrees. Then we start to get the leg down to a more dependent position. It's going to be the partial chair position. Then when things gets better, you raise the head of the bed more to 65 degrees and the leg to fully dependent position to be a full chair position. You can also sometimes use the mechanical hoist in some patients to maintain their chair position in some condition, if feasible in the institution. And the tilt table, it's an option, but it's not available everywhere too. When the patient starts to get more conscious and interactive, you get the patient you get the patient up from the bed, sit in the chair, and help to support first 1 or 2 steps. Then when they start to move more and get more independent, you walk with them, walk with assistance, then they start to walk independently. Again, the patients are intubated. No, this is not an obstacle. When we exclude the patients, or we think that they are not, it's not going to be safe for them to participate in the physical therapy, if they have cardiovascular instability like hypotension, the patient is hypotensive, less than 90, tachycardic, unstable cardiac rhythm, having 2 or more vasopressors or the inotropes need frequently be uptitrated. The respiratory problems, if the patient is requiring a lot of oxygen, like FI2 more than 60%, peak more than 10, the patient is tachypnic, requiring any paralytic agents, and the neuromuscular instability, if the patient has any primary CNS injury, if the patient is getting ICP monitoring, if there is an intraventricular drain, any neurological deterioration. Also, some other interventions that we do might affect and initiate the step of physical therapy, like if the patient has a femoral sheath. Femoral central lines are not a contraindications. Our femoral arterial lines is questionable, might prevent, but the patient can do some exercises and early exercises, and day by day, if we are able to move it to a different place, we can try to move the patient up and walk. If the patient in trauma and has a balanced skeletal traction, if the patient has intra-aortic balloon pump, active bleeding, all of these are contraindication for starting the physical therapy that early. There is a screening algorithm that was published in one of the meta-analysis to assess the patient's need, to assess when to start physical therapy and how to proceed. So you start first assessing their their neurological function, and if they are opening their eyes to verbal stimuli. If not, the question is it related to our interventions, the medications, the sedation, and what we can do? Can we start doing more sedation vacation, add antipsychotic agents to help minimizing the sedation? Is there any of the medications that we give can cause the patient more agitated or restless? If the patient has a primary CNS problem, so it's going to be a problem and you can be assessed later. If the patient is the next step is going to be assessment of the respiratory and cardiovascular criteria. If the patient is in high settings on the vent or has cardiovascular instability, so if the patient has one or more of these criteria, you need careful assessment of these patients, and you can see exactly what can start and what not, and in collaboration with the physical therapy team. If any of these problems, the physical therapy team can be consulted and come early. If any of these problems happen with the physical therapy, like hypoxemia, patient drops his oxygen less than 88, tachypnea, acidosis, hypotension, or new DVT, or during the course of the therapy, if any one or more of these happen, like the ICU physician can assess the appropriateness of the therapy, also in discussion with the physical therapy team. And if nothing, the physical therapy can continue. We try to make it easier and overcome barriers by many steps. First, all the sedation. The sedation is very important to be assessed every day. And the need for sedation and the sedation protocols, the vacations, and the goal-directed sedation, we need to minimize it as much as possible to get the patient more awake and help to participate in the physical therapy interventions. That's going to help with his delirium too. There were studies talked about the cognitive impairment and the early mobilization and its impact, but I tried to get my presentation as more concise as possible. But that's very important step. Also, the human and technological resources. The personnel in the ICU should be trained and educated every day and about the positive outcomes of early mobilization and physical therapy, and the safety as well. You have to talk to your nurses and the team about their concerns about the safety, and sometimes if it makes sense or the patient what's considered to be an obstacle for moving the patient or mobilizing is really have any risk, concerns, or can be dealt with. And proper lifting equipment, and that's basically provided by the physical therapy. So what's the financial impact of early mobilization? It was studied in Johns Hopkins on a 24-bed unit with 900 annual admissions. They found the length of stay decreased by 22%, with net cost saving more than $800,000. In a hospital with 2,000 ICU admissions, the net cost saving can project to 2.2 to 3.7 million. After the investment of about $600,000 on physical therapy, including the salaries, the equipment, and the rest of that. Knowing in Henry Ford, the MICU had more than 4,000 ICU admissions per year, like in 2014. So you can imagine how much the saving and the cost saving if we have this early rehabilitation program. Sorry. So at Henry Ford. So let me talk about it. Okay. So at Henry Ford, so as I mentioned earlier, it has an impact in the studies on the length of stay, the mechanical ventilation, which is going to affect the cost of care too. At Henry Ford, they sent surveys to through the SurveyMonkey to 132 hospitals in 26 states. And they included in the hospitals, they did not include the hospitals that have the early rehabilitation intervention programs. The nearby programs that we have, it's University of Michigan and Beaumont. Actually, they have early intervention programs. So such programs did not include it. And they found that 71% of the hospital reported that ICU patients are seen once or twice daily by the physical therapy team. And 93% reported that the patients seen 3 times per week. At Henry Ford, the physical therapy see the patients as needed and typically 2 times per week. So according to this and Johns Hopkins study and the impact of early rehabilitation, there is a pilot study now at Pod 1, applied in Pod 1. The physical therapy team, the PT and OT team, they start early as in the first 12 to 24 hours, assessing the patients rather than the 48 and 24 to 48 hours in the other units. The other units, the nurse is the first one assessing the mobility and the need for physical therapy. And in Pod 1, physical therapy, PT and OT are involved from the first day, maybe from the first 12 hours or even earlier. And they do their sessions daily, even during the weekends. If you go to Pod 1 at any time, you're going to find the mobility team and the physical therapy team. On the other hand, it's as needed, and in the other units, which we've been following, and no more than 2 to 3 times per week. I took this photo from Pod 1. This is the WE unit. We actually started to apply the WE. You're going to ask me where's the WE? It's inside this box. It's locked here to make sure that fellows or residents not going to use it. So the physical therapy team and OT, they started to implement these interventions. Actually, they had one of, like last week, an intubated patient, ventilated, was able to get up and was able to use the WE and cooperate with the physical therapy team, and they were so excited with it. Boxing, bowling, and this balance board. Yeah. So I hope they start to implement the PlayStation 4, man. And also they do with the cycling, the upper and lower extremity cycling. They try to collect the data and to see the overall hospital length of stay, the unit length of stay at Henry Ford, and the cost saving going to be calculated according to the Johns Hopkins published tool. And they're going to assess also the quality measures, the highest level of mobility achieved in the MICU. Compare this in Pod 1 with the other units and see how much impact we get with this for further funding and try to implement the early rehabilitation programs. The goal is that all the hospitalized patients should have a detailed and specific activity program initiating on the admission and on follow-up. Try to get them moving and makes difference. So my take-home points of my presentation: bed rest and immobilization is associated with multiple complications we should be aware of, increasing the needs for physical therapy and expanding the ICU care and rising numbers of survivors. Early mobilization showed improved outcome in physical function, length of mechanical ventilation, ICU stay, muscle strength, and quality of life. Early mobilization is safe even with the mechanically ventilated patients, and goals achieving maximum level of independence before the hospital discharge. I hope you guys are still awake and able to ask questions. Any questions? It should be. It should be like. And the problem is that what we face in the round sometimes, like we after consulting the physical therapy, we find out by the end of the day that they came in and they were not able to intervene and they just left. So the problem is bringing them back on the same day, but we should be able to talk with the mobility team in the morning in the multidisciplinary round and address their concerns about the patients and see exactly what's feasible, what can be done for the patients.
In Parliament, we're doing a lot of work myself and the PTOT team actually around all of that. And even in mental setting, but I mean, I didn't know that all this is clear, but with patient like 1.5, 2 months of labor, I never told them to solve it.
Exactly.
People actually listen to us and I said, this is okay, full perspective.
Exactly.
So,
If they are concerned,
listen to us, whatever people,
yes.
they never said no.
So if you haven't been in Taiwan and the fellow you met, you really don't know that, no. But they're having a fellow run some of the patients that really and so just go by the bed and say, that's what I'm going to do, whatever it is. So it's not that very helpful. We don't have a mobility team. A lot of the independent, so the nurses are mobility, but you can go to it there and we've been able to not only read it, I think, outside last week, actually took them outside, we got a patient down to the roof room that was colder, we were on the bench, and so they're actually looking at the innovation computer now. There's a high school walker that they can do a mobile bed